Welcome to the OMM-Medicine's module on shock. So there are many different types of shock, as you can see listed here, each with their own specific characteristics and presentations. And in reality of actual practice, shock is typically going to be a mixed picture between multiple of these types of shock. It's very rare that you will get just hypovolemic shock or just cardiogenic shock. Usually it's going to be a mix between one or two different types of shock. So the first type of shock we'll talk about is hypovolemic shock, and this is going to be caused by a loss of intravascular volume. And one of the most common causes is going to be hemorrhage or a patient who is acutely bleeding. Now there are non-hemorrhagic causes of hypovolemic shock in which we are losing intravascular volume from a source that is not an acute bleed, and these are typically going to be patients who have large burns, heat stroke, or diarrhea. And the treatment of hypovolemic shock is pretty straightforward. Remember that we have low intravascular volume, and that's what's causing poor perfusion of organs and ultimately shock. So the treatment is going to be to increase the intravascular volume, and there's two major ways we can do this. We can provide fluids such as normal saline or lactated ringers, or if the patient is hemorrhaging, then we can provide blood products which also provide a decent amount of intravascular volume. Now, if fluids or blood products are not adequate at treating the hypovolemic shock, then we can consider the use of albumin to help draw in the fluid back into the vascular space. And if all else fails, then we can use pressors, things like norepinephrine or epinephrine. And a key item to remember is that when treating hypovolemic shock, we're always going to want to use fluids first before we add on pressors. The next type of shock that we'll talk about is distributive shock, and this is caused by severe peripheral vasodilation due to some underlying trigger. So one of the most common causes of distributive shock is going to be sepsis, and in this case an infection causes diffuse peripheral vasodilation leading to shock. And two other very common causes of distributive shock are going to be anaphylaxis and pancreatitis. So the treatment of distributive shock is going to be very similar to that of hypovolemic shock, meaning that we will first start with fluids. Typically we'll bolus 30 cc's per kilogram, and that's going to be administered over the first 3 hours from the onset of shock. And then if fluids are not adequate at managing the hypotension and the shock, then we will then use pressors, things like norepinephrine or epinephrine. It's also important to point out that if the patient is having distributive shock from something like anaphylaxis, then obviously we would want to use epinephrine to treat the anaphylaxis and hopefully resolve the distributive shock as well. The next type of shock we'll discuss is neurogenic shock, which is actually a subtype of distributive shock but has its own specific cause, which is disruption of the autonomic nervous system. So when we disrupt the autonomic nervous system, we're going to get fluctuations in vagal tone, and therefore we'll get hemodynamic instability because the blood vessels are essentially saying we don't know whether to vasodilate or vasoconstrict, and this will ultimately lead to shock. So the main causes of neurogenic shock are typically going to be traumatic in nature. These are things like traumatic brain injuries, spinal cord injuries, whether it be from a car accident or other cause. And the treatment is going to be very similar to that of the distributive shock, which we just mentioned. So typically is going to be treated with fluids and pressors as needed. The next type of shock we'll talk about is cardiogenic shock, which is shock that results from an intrinsic failure of the heart to pump, meaning that the heart is no longer able to perform its ability to pump blood to the rest of the body. So if cardiogenic shock is the inability of the heart to pump blood to the rest of the body, then it should make sense to you that the major causes of cardiogenic shock are going to be those things that cause a direct insult to the heart itself. So the major causes of cardiogenic shock are going to be large myocardial infarctions or heart attacks, severe heart failure exacerbations, or severe aortic and mitral insufficiency, which therefore can result in heart failure and its inability to pump blood. So in cardiogenic shock, our issue is not a low amount of intravascular volume, and our issue is not peripheral vasodilation. Our issue is that the heart cannot pump adequately. And so the treatment for cardiogenic shock is not going to be fluids or pressors. The treatment is going to be something that helps the heart pump better. And so we will use positive inotropes such as dobutamine to help the heart pump and help relieve the shock. Now remember, in reality, it's very rare to have one type of shock isolated. You will typically have a mixed picture between two or more types of shock. However, for your board exams, if a patient goes into cardiogenic shock after a large myocardial infarction, for example, the treatment that you should choose should be a positive inotrope such as dobutamine. You should not be treating these patients with pressors or fluids unless there's another indication to do so. The last type of shock we'll talk about is obstructive shock, which is caused by poor cardiac function due to a cause that is not the heart itself. So what does that mean? Well, this means that the heart muscle and tissue itself is normal and can beat and pump blood just fine. However, there's another issue, such as a pulmonary embolism or pericardial tamponade or even a tension pneumothorax, that is causing the heart to have to pump harder than it normally should, and therefore the heart cannot meet the new demand. So for example, in a pulmonary embolism, we're going to have blockage of the pulmonary vasculature, and this is going to cause increased afterload, which requires the heart to pump harder against this increased afterload. And so therefore the heart is unable to meet this new demand, and we will have something called obstructive shock. And the treatment for obstructive shock is pretty straightforward. It is just to relieve the underlying obstruction. So if the patient has a pulmonary embolism, we will want to provide anticoagulation. If they have a tension pneumothorax, we would consider a chest tube. If they had tamponade, you could consider a pericardiocentesis or a pericardial window, and so on. And that brings us to the end of this module on shock.